First question.
My name's Rebecca Street. I'm a physician from Milwaukee, Wisconsin, where it's been really cold for about 5 months. So I'm glad to be in LA. This is my first DFCon, and I really enjoyed it. So I recommend it to all my colleagues. I'm boarded in internal medicine and hyperbaric medicine, but I'm not going to pick on hyperbaric medicine because I really enjoyed the lecture. I had just more comments than questions. I work for a large health system in Wisconsin, Aurora Healthcare, and it's a very hyperbaric heavy health system. We have 10 hospitals. I think 8 of them have hyperbaric programs. Our medical director is the immediate past president of the UHMS, and so we're not a kind of a pop-up freestanding hyperbaric wound center that we're seeing kind of pop up all over the country. But I'm constantly being asked by our administrators and bean counters, your numbers for diving diabetic foot ulcers are lower than anyone else. You're outside the bell curve for the number of diabetics. Why don't you have more Wagner 3 ulcers? I have a nice community hospital, a very affluent area outside Milwaukee. And they said, are they that good at taking care of diabetes out there in the suburbs if there's not more Wagner 3 ulcers? And I said, if you look at why an ulcer gets to the Wagner 3 stage, either their A1C is in the double digits, or they're smoking, or they're not offloading, or they're not compliant, frankly, and you're not going to change that with hyperbaric treatment. It's not the Lazarus chamber. You don't put people in for any reason and they pop up, fine. But I also think that, I looked at why are my colleagues having such, prolific numbers of diving diabetics, and a lot of them, frankly, call a Wagner 2 a Wagner 3 because they're going to get reimbursed by CMS. And I think that's driven a lot by the fact that hyperbaric revenue drives a lot of wound centers because you're not going to even break even on your wound care. And I think the more we see, freestanding wound centers kind of pop up on the corner next to Starbucks, we're going to continue to see, diseases looking for hyperbaric hyperbaric looking for indications. And I don't want to bite the hand that feeds me, and I think it does wonderful things for radiation injury. I've seen wonderful things for, threatened flaps and grafts, but I think we really have to look at, is this really the best treatment for a Wagner 3 diabetic ulcer? I think it's, we say, well, it's safe, it's not harmful. There's a seizure 1 in every 7,000 treatments, but it's very expensive. It's very time-consuming for patients. It's disruptive to their lives. It's a rare working patient that can do hyperbaric because it's 2 hours a day, 5 days a week, 6 to 8 weeks. And then they go out of the hyperbaric chamber, put on their steel-toed boots, and stand on their feet all day. I mean, you're just, it doesn't make sense to me inherently that it should work to change the mechanism of the injury. And I also think it's a passive treatment. The patient lays in the chamber. I'm safe. I'm going to heal because I'm breathing 100% oxygen at pressure. I don't have to do anything more because this oxygen is going to fix my wound. And I think that's a disservice. And I think it kind of falls sometimes into the realm of the fiddling and diddling that we do rather than something definitive as in, good orthopedic or prosthetic care. If there's limited dollars to go around, of which seems to be, I'd rather that my podiatrist gets reimbursed than the hyperbaric gets paid for. So
you talk about biting the hand that feeds you. You do realize this is being streamed to a couple thousand people.
That's all right. I don't need a job that bad.
Oh, well, that's a nice position to be in. Let me ask Dr. Margolis. One of the things I found very amazing, actually, in your study was all of your data was from one of the largest commercial hyperbaric providers in the United States, who should be following the CMS guidelines, as the doctor mentioned, and only diving grade 3 ulcerations. Yet I believe 75% of your ulcers were grade 2.
I don't remember.
It was it was a huge number compared to the grade 3.
I don't think it was 75, but I don't know. I didn't review that for today's discussion.
Yeah.
But I certainly, I think we have a speaker for next year.
No, not if it's during March Madness. That's my only complaint.
So, I think it's interesting. These selection criteria get created that we're supposed to follow, and sometimes it's not clear to me whether or not they've been created in a way to make the treatment most effective, or to try to limit the amount of expense. That sometimes I think policy is used for cost containment instead of maybe what's best for the patient. And it might be there might be better success with grade 2 than grade 3, provided that it is effective treatment, which I have my own skepticism about. But You know, I mean, it's fairly arbitrary, right? They
Yes.
said 2 versus 3. That's an arbitrary decision that was made, and, you know, the policy reasons for making that may have nothing to do with trying to come up with a treatment that works for the patient.
Well, I
I
mean,
think it
frankly,
was
there have been
supposed to-
issues. There have been issues with the Wagner classification as a classification for diabetic foot forever. I mean, it's not, in fact, an appropriate diabetic foot classification. It was never meant to be. That's not how Wagner originally wrote it. Dr. Armstrong is patiently or impatiently waiting to give a comment.
First of all, I thought that, Doctor, that soliloquy was, it's recorded, and it's not, I don't think it's a screed against hyperbaric. I mean, there's very likely, as you said, I think there are indications for it, but I think it was, I mean, that was friggin' Shakespearean. It was like To Be or Not to Be with O2. That was just great. But to that point, to the very point that you came about, this definition of a Wagner 3 is ridiculous. Because Wagner 3 is osteitis or abscess.
Right.
So are we sticking people with abscesses that are bursting under oxygen? This has never made any sense. And so you have this criterion where thousands of people are getting treated, and yet that is the, that's the song sheet to which we're trying to sing. Dr. Margolis.
But, I mean, also, it's important to realize if you look at the RCTs, they all treated Wagner too. I mean, how CMS came up with their criteria, or Undersea Hyperbaric Medicine Society came up with their criteria, since they're fairly similar, I'm not certain, because it certainly wasn't based on the available literature necessarily. The other thing they answered to what was mentioned before, which I think was an exquisitely important comment that was made. But there's at least 2 or 3 studies now that have come out that have shown that the sooner you treat patients, the better they do, regardless. And there was at least one study that I can quote, because it was one of my own from a few years ago, that looked at a large wound care system who claimed that over time they were doing better and better at treating wounds. And they claimed it was because of their own skills. Now, it may have been, but they were also attracting earlier and earlier wounds, right? So one could argue that if you're not seeing many grade 3 wounds, it's because you're doing a good job of community outreach and you're seeing people earlier and you're seeing wounds that are eminently more treatable. So you should actually be applauded, not criticized for not seeing those wounds.
The Godfather.
Well, to that point, I found that one of the great problems we have is that questionable interventions, be they hyperbaric or aggressive angioplasty in the patient that may need a bypass, are rather expensive forms of delay. And we all know delay is a problem. The question I have for all the members of the panel, what happens to these people when it is decided that they're going to go into the hyperbaric chamber? Do people lose interest in the usual things, as other people have said before? Do they just say, once we get them out of the hyperbaric chamber, we'll then go back to aggressive offloading and debridement and all of the routine care? And as much as I'm uncertain about the efficacy and effectiveness of hyperbarics, I'm also uncertain that these patients may fall out of the system, as it were, of normal care as they've been relegated to these other modalities. I'd like to hear a comment from the speakers.
Don't look at me. You guys are the experts.
But you have the big podium.
So, you know, George, in my practice, I do use hyperbaric therapy occasionally, but I use it as an adjunct to things I've already done. So, for example, just recently I had a woman, she's a longstanding diabetic, has a kidney transplant, and has tibial disease and has very poor runoff, did not have a pedal or a tarsal target, seeing more as time goes on. Did a anterior tibial angioplasty, and she had toe gangrene, dry gangrene of a toe, amputated her toe afterwards, and the pulse volume recordings were, there was some fluctuance at the undulating wave line after I did it, but not great, but I thought it was as good as we can do. We did it, we closed it, and it was draining a little bit, not infected, just we weren't getting the skin to come together. I put her in the hyperbaric chamber, and she healed in 2 weeks. So I think in that case, I was impressed that it worked. And I was a little concerned that if I'd waited much longer, infection would have had to probably convert to a TMA or who knows what. So in that case, it worked. I've had some other people kind of like that, where I've kind of done as revascularization that's marginal in a bad situation and tried it for wound healing, and it worked, but not the other way around.
But also what you're saying is really important in terms of the concept of efficacy versus effectiveness. And efficacy is what happens in an ideal situation. And in randomized clinical trials, things are ideal. So if HBO is meant to be an adjuvant and good offloading is important, it's going to happen in the efficacy study. It may not happen in the effectiveness in the real world. And I mean, it should be easy to test that and see what was going on in those patients, but that may be why both sets of studies are correct. The RCTs are right if you do everything the way you're supposed to. The cohort effectiveness study that we did is right if you do what's really happening, where maybe people are forgetting to offload, or patients think if they sit in a chamber for an hour or two, all these magical things are going to happen to them, and they don't need to offload, and they don't need to worry about debridement, and don't need to worry about control of infection and all sorts of other things.
Frank,
I use it rarely, and so I can't comment on whether or not it works. I will say that it's used in my community, and I've seen a number of patients who did not get an adequate vascular evaluation before being put in there. And once they're put in there, it's sort of like that's the plan for the next, I don't know how many months, and they don't reevaluate it until it's over. So I think that's a problem. I would also point out, and I would certainly defer to my more established epidemiology colleague here, but the biggest problem, I think, in the literature is actually observer bias, and you can't blind treatment. So this is the kind of study that you can't have blinding in, and that's the biggest problem in the literature. You can't evaluate really whether or not this is working. And you can look at a million diseases, including Parkinson's disease, where things worked until they actually were really tested in a big way, and then they ended up not working. There's a lot of potential here for people to want to believe it's working when they go in. And if you don't really have very strong objective evidence, I think it looks a little dicey.
Yes, sir.
Okay, I want to tell you a story before my question, my observation. A couple of weeks ago, a patient with a critical limb ischemia asked me, I have a chance to come back to work? Why, I asked. Because I have lost my 20 years old daughter for an accident, and work is the only reason to survive for me. So I tell you this story to say that not always the choice between amputation and limb salvage can be taken so easily. And my observation to Dr. Conte is the following. Even if and we are sure that surgical bypass is better than PTA, the problem that we have now is the number of patients. And we know that the diabetic patients with PVD are 1/3 of the patients. And we know that not all those patients can be treated with PVD. And we have, on the other side, some evidences that the lower limb amputation is going to be reduced in the last year. In the United States, it's 37%. In Italy, we have 30%. And this is it comes together with the increased number of PTA. So I think that we should think differently. We have not to decide what is better. But I think we should work to find the best way to use the one of the other. Because PTA cannot, surgical bypass cannot be used for patients with renal disease, on dialysis. There are too many comorbidities that cannot be treated by surgical bypass. And we treat by PTA a lot of other old patients. So the solution to have a major amputation as a first choice, I think is a way to think that we have to lose. It's no longer the way to treat our patients. So I think that our effort is just to stabilize what kind of patients can have really advantage from one technique and the other one.
Thank you for that comment, Dr. Conte.
Yeah, I think we, as I understand your comment, we mostly agree that there is a role for both types of therapy in the right patient. I think where maybe we don't agree is I think the idea that every patient should get an endovascular treatment first, which is espoused in the literature in some places and on the podium in many places, I think is actually dangerous. Not only do I think it's not right, I actually think it's a dangerous message. The second thing, I think, is just a slightly different interpretation of the amputation rates. The amputation rates were dropping well before the rise of endovascular interventions and probably reflect medical management of the diseases, just like the major mortality rates from cardiovascular disease have been dropping. So I don't think we can congratulate ourselves about exactly why the rates were dropping. But the point really is that both treatments have a role. Don't basically look at it as a hammer and a nail problem and try to force feed endovascular into every patient first, because some patients will be poorly served that way.
I'd also like to point out just briefly that I don't agree with your comment that you can't do bypasses in patients with end-stage renal disease. I've done many bypasses over the course of my career in patients on dialysis, and it's true that the results are not as good as in patients who have normal or relatively normal kidney function, but they're still pretty good. And I would submit that in my practice in terms of endovascular therapy, that those patients are extraordinarily difficult to treat with percutaneous interventions. In fact, that's where I've had the highest likelihood of technical failure.
Yeah, we're almost out of time. Last question, sir.
Just a quick comment for Dr. Margolis. Thank you for citing Gord Guyot's paper from Hamilton, Ontario. That's where I'm from, by the way.
Were you on it?
The paper from Gord Guyot.
No, were you on that paper?
I was not on that paper, but he's my friend, so I'll just say that. It's interesting about the hyperbaric, but not to belabor this thing, but would it get as much attention? And obviously, it's an important question to answer. But would it be getting as much attention if it wasn't so massively reimbursed? And it's wickedly reimbursed here in the United States, but in Canada, you get about $100 a dive. So if you're into it, where I'm from, you got to figure out the business model really carefully. And there's people that are doing it that are making money, but $100 a dive versus $1,500 a dive it's a different matter altogether. And would we be getting this kind of, well, I mean, it's a question that needs to be answered, but would it be this heated? Or would the government, or would the people, the funders, because I think that the people that are into it in the States are worried now whether the plug is going to be pulled on their funding?
Right. So I don't know the answer to your question. I mean, I can tell you who called to complain after the paper was published. I mean, they were all people who are hyperbaric oxygen specialists pretty much, and most of them, after they vented for 2 or 3 minutes, I then asked if they had actually read the paper, and most of them had only read the title. Occasionally they'd read the abstract. A few of them called back after they read the paper and said, "Oh, I understand," and it's sort of I understand, and maybe it's fair. So I don't know. I mean, certainly the people that responded to the paper were primarily people who use hyperbaric oxygen. The other way of looking at it is those are the people you hope would have read the paper, since they're the ones using it. So I don't know what to say. I haven't had many people call from Europe or Canada complaining, if that's no. Yeah, although it's free on Skype. And
I want to thank the panel very much for a very good discussion on this topic.